Thank you for joining our training on the 2018 Impairment Guidelines for determining schedule loss of use. This training will help you apply the 2018 Impairment Guidelines to assess residual, permanent, physical, and functional impairments in a worker with a scheduled permanent partial disability. To understand the evolution of the 2018 Impairment Guidelines, a history of the Impairment Guidelines will be covered first, including a summary of the progression of changes that took place from the 1996 guidelines to the 2012 guidelines, and from the 2012 guidelines to the 2018 guidelines. In addition, we will describe the physician's important role in the medical evaluation of permanent impairment, including how to apply some key terms and principles in the approach to performing an SLU determination. Finally, this training will provide some practice applying the objective criteria in the impairment guidelines by walking you through some sample medical impairment evaluations, quizzes, and case studies. First, let's review the history of the impairment guidelines. The medical guidelines were first issued in 1996 for the evaluation of permanent impairment for both schedule and non-schedule injuries. These guidelines were in effect through 2011. In 2012, the Board issued Medical Impairment and Loss of Wage Earning Capacity Guidelines, also known as the 2012 Guidelines. These guidelines addressed both schedule and non-schedule awards and contained new criteria for evaluating non-schedule impairment. In 2017, workers' compensation legislation directed the Board to adopt revised guidelines for SLU injuries. The revised SLU guidelines were developed and implemented on January 1, 2018. These 2018 guidelines reflect advances in modern medicine that enhance healing and result in better outcomes. The changes from the 2012 guidelines to the new 2018 guidelines involve the SLU material and a new introduction. As a result of these changes, please note that chapters 2 through 8 in the 2012 guidelines are no longer in effect for the evaluation of SLU effective January 1, 2018. The non-scheduled PPD chapters in the 2012 guidelines, chapters 9 through 17, remain in effect for the evaluation of non-scheduled injuries. There is important legal information about providing medical care in New York's workers' compensation system that you should know. So let's take a brief look at that before going into detail about the 2018 Impairment Guidelines. New York State medical providers must be board authorized. Board authorized means authorized by the New York State Workers Compensation Board to treat and/or perform independent medical evaluations of injured workers. Permanency evaluations performed outside of New York State must be consistent with the Impairment Guidelines. There are also revised board forms that must be used to document SLU. We'll discuss these in the last section of the presentation. One of the most frequently asked questions during the transition to the 2018 Impairment Guidelines has been, when do you use the 2018 guidelines and when do you use the 2012 guidelines for SLU determinations? So for clarity, let's review. When the first medical evaluation of SLU was performed before 1/1/2018, the Board will determine the worker's degree of permanent disability using the 2012 guidelines. If the first medical evaluation for SLU occurs on or after January 1, 2018, the SLU determination will be made using the 2018 guidelines. To begin the review of the 2018 guidelines, let's start with a walkthrough of the table of contents. This will help you identify the location of each body part and/or condition that is amenable to an SLU evaluation. The introductory chapter contains key concepts and terms that are important in SLU evaluations. Each chapter discusses the SLU evaluation of an individual body part or condition. Chapters 2 through 5 address the evaluation of the upper extremities, while chapters 6 through 9 discuss the lower extremities, specifically hip and femur in Chapter 6 and knee and tibia in Chapter 7. Chapter 10 covers central nervous system conditions and injuries, and Chapter 11 the visual and auditory systems, facial scars, and disfigurement. Importantly, the 2012 Guidelines SLU chapters have been updated. The updated and revised chapters are now chapters 2 through 9 of the 2018 Guidelines. Chapters 10 and 11 in the 2018 Guidelines have been brought forward from the 2012 Guidelines and are unchanged. Let's take a moment to review some of the key concepts and terms from the 2018 Guidelines. Chapter 1 also contains information on the role of the examining medical provider, which will be discussed in detail later in this presentation. What is the difference between impairment and disability? Impairment is a purely medical determination made by a medical professional and is defined as any anatomic or functional abnormality or loss. It requires a complete examination and an accurate objective assessment. Residual impairment is considered permanent at maximum medical improvement. Disability, on the other hand, is a legal determination that falls within the purview of the board. It reflects the impact of a workplace injury on a worker's ability to work. A workers' compensation law judge establishes a level of disability based on the available medical evidence and other relevant information. Maximum medical improvement means that the worker has recovered to the greatest extent expected, and that no further improvement in his or her condition is reasonably expected. A few additional facts regarding maximum medical improvement. The need for palliative or symptomatic treatment does not preclude a finding of maximum medical improvement. Additionally, maximum medical improvement cannot typically be determined before 6 months from the date of injury, unless the parties agree. Here's some additional information regarding chapters 2 through 9. Each chapter is organized into sections that define the criteria and approach to the SLU evaluation for the identified body part or condition. The first section is Objectives for Determining Impairment. This section provides an overview of the function of the involved joint and what is required for an accurate assessment of the permanent residual deficit from the work injury. The assessment should be based on objective findings determined by history, exam, and results of any appropriate diagnostic testing. The second section, Methods Available to Assess Permanent Impairment, provides instruction that the determination of the degree of permanent residual physical deficits should be performed at maximum medical improvement. Additionally, the contralateral side should be considered for comparison when appropriate. It is important to understand that the severity of a permanent impairment is not based on the mechanism of injury. It reflects the permanent residual impairment that occurs at maximum medical improvement and may include damage to a variety of tissues, including bone, muscle, cartilage, tendons, etc. The duration of time for maximum medical improvement varies, and in most cases is 1 year from injury or last surgery. Subsequent sections in each chapter provide normal ROM tables, the method for calculating the overall SLU for the body part, special considerations in the percent loss of use for amputations at different levels of the involved body part. The introductory chapter focuses on the physician's critical role in the SLU evaluation process. Physicians must provide the board and all involved parties with their best professional medical opinion regarding a worker's SLU impairment. It's expected that a physician will apply the detailed criteria in the guidelines to the objective findings of the physical exam and the data contained in the patient's medical records to determine the severity of the SLU impairment. Note the following new documentation requirements. When preparing a report, the documentation must specifically identify the affected body part or parts, include chapter number or numbers from the 2018 guidelines, and include a review of the applicable sections of the guidelines that have been utilized. The physician must report the work-related diagnosis and specifically report the relevant history, examination, and test result findings when applying the guideline criteria to establish an impairment level. The clinical information must support the SLU determination. Now let's turn our attention to the range of motion criteria. range of motion is a key factor in the SLU determination in the 2018 impairment guidelines. Generally, a goniometer should be used to measure active range of motion. There are several new requirements that must be met when evaluating range of motion. 3 repeat measurements should be taken of the maximum active range of motion. All 3 measurements should be reported, and the highest should be used in the SLU determination. When evaluating residual impairment, the contralateral side should be considered for comparison for expected or normal values when appropriate. Deficits should be compared to the baseline reading of the contralateral member. Using the contralateral side is not appropriate when there has been a previous injury to the opposite side resulting in a functional impairment, or when the contralateral side is not otherwise available for comparison. When the contralateral side is not available or not appropriate, the normal range of motion from the tables in the 2018 guidelines should be used as a baseline comparison. Next, we'll practice evaluating range of motion with 2 quizzes. Please note that 3 range of motion measurements have not been included in the examples illustrating the quizzes. However, each quiz assumes that 3 measurements were taken and that the ROM used in each case is the highest range of motion value. So let's begin with quiz number 1. A provider documents that an injured worker can only achieve 150 degrees of flexion in the healthy, unaffected right shoulder. The guidelines state interior flexion in a normal shoulder is 180 degrees. In determining the SLU for the injured left shoulder, what is the starting point? Is it A, 150 degrees, B, 180 degrees, or C, neither? The answer to quiz 1 is A, 150 degrees is a correct answer. Let's look at why. When evaluating the level of a permanent residual range of motion deficit, the provider should compare the range of motion to the unaffected contralateral side. When appropriate, the contralateral value should be the norm used to calculate the SLU percentage. In this case, the healthy unaffected shoulder's ROM of 150 degrees would be used as the baseline ROM. Quiz number 2 involves a more complicated case. The worker injured his right shoulder. The unaffected left shoulder has a forward flexion of 140 degrees due to body habitus restrictions. According to the guidelines, normal shoulder forward flexion is 180 degrees. The right injured shoulder obtains forward flexion of 45 degrees. What is the right shoulder SLU? Is it A, 60%, B, 78%, or C, 47%? The answer is C, 47%. Let's look at why. Flexion of the unaffected shoulder at 140 degrees becomes the baseline and is used to calculate the SLU for the injured shoulder. To obtain the percentage SLU, first determine the ratio of the range of motion of the unaffected shoulder compared to the normal range of motion from the guidelines table. The unaffected contralateral ROM of 140 degrees becomes a numerator in the ratio, while the normal ROM of 180 degrees from the guidelines table becomes the denominator. 140 degrees over 180 degrees equals 78%. If you look at the shoulder table in the 2018 guidelines, you can see that the range of motion for this injured worker would fall into a marked or 60% category, and range of motion of 45 degrees would equal 60%. However, because a patient's contralateral baseline represents 78% of normal, the calculation of the worker's SLU would be 60%, or guideline normal, multiplied by 78%, the patient's contralateral baseline value, resulting in 47% SLU. Now let's look at some of the rules for range of motion deficits. For SLU determinations, total SLU for several range of motion deficits within a joint cannot exceed the value of full ankylosis of the joint. When there are multiple ankylosed joints, the sum of the value of the SLU of the major member cannot exceed the value of an amputation for that member. An exception to these rules may occur when digits exceed these values due to loading. There have been some significant enhancements to the 2018 guidelines that help to clarify important aspects of the SLU evaluation. First, the development of written instructions and visual aids for each body part make it easier to properly measure all range of motion deficits within a joint. For example, let's look at Chapter 5, Upper Extremities, Shoulder. The specific instructions regarding shoulder flexion and extension are seen in this slide. And combined with diagrams, aid in clearly defining what is measured, how the measurements should be made, and the normal values for the ROM measurements. The new guidelines clearly identify the ROM values that correlate with mild, moderate, and marked deficits. Example, Chapter 3, Section 3.3, Wrist dorsi and palmar flexion. We will explore this further in Chapter 3. Using the wrist guidelines as an example, the diagram of wrist dorsi flexion and palmar flexion clearly correlates deficits in wrist ROM and with percent loss of use. In the related table, in this case Table 3.4, the ROM values and percent loss of use are clearly identified into mild, moderate, and marked categories. The 2018 guidelines contain a step-by-step explanation of loading. Values for loading that involve the fingers have been increased by 20% to address the increasing reliance on the hand and fingers in the computer age. There have also been some changes in the special considerations sections. An overarching change to take note of is that the instructions have been clarified regarding whether a condition that falls under special consideration is a standalone or an add-on value. New is that considerations for meniscal and rotator cuff tears, with or without surgery, have been removed from special considerations. The content for joint replacements has changed significantly. Advances in medicine have improved many joint replacement outcomes, and the 2018 guidelines provide an assessment of clinical outcomes to determine an SLU. These clinical criteria include an overall grade, range of motion, position, atrophy, and complications. The starting point for an SLU in a joint replacement with a good outcome is 35%. Additional deficits are added to this baseline. Any additional deficits would be chosen from the relevant columns that have the closest matching deficit to the patient's deficits. Quiz number 3 provides an illustration on how to perform an SLU evaluation for a patient with a joint replacement. A worker is status post-hip replacement surgery. At maximum medical improvement, the following clinical findings are noted. The range of motion, which is more limited in flexion to 45 degrees. There is a leg length discrepancy of 0.8 inches, and malrotation is present at 20 degrees. So what is the SLU determination for this patient? Is it A, 35%, B, 55%, or C, 45%? The correct answer in this case is B, 55%. To understand the answer, let's review Table 6.5, hip replacement. For a hip replacement, 35% is the starting point. In this case, the patient's hip flexion falls into the fair category of 45 degrees, and therefore an additional 10% is added for the flexion deficit. Malrotation of 20 degrees falls into the poor category and another 10%, with 35% as a starting point, plus the 10% from the flexion deficit and the 10% from the malrotation, the total SLU in this case is 55%. You should be aware of a few other items about the table values. Some percent loss of use associated with a ROM deficit are displayed as a range of percent loss of use. When a range of percent loss of use is associated with a specific ROM value, the lower percent loss of use should be used when there is a deficit in only one joint ROM. For example, only flexion is affected. When there are deficits in two corresponding ROMs, for example, both flexion and extension within a joint are affected, the higher percent loss of use value is used. For example, in Chapter 2, Upper Extremities, Thumb and Fingers, Table 2.5b, you'll see that the moderate percent loss of the MCP joint ranges between 30 to 40%. If there was only a loss of flexion, then the SLU would be the lower value, or 30%. If there was a deficit in both flexion and extension, the SLU would be 40%. Another important change in the use of ROM for determining SLU is in the determination of the shoulder SLU. In the shoulder, if there is a deficit in both flexion and abduction, the greater of the two deficits must be used in the SLU calculation, not both. Now that we've reviewed the guidelines content, let's walk through the SLU evaluation process and highlight the new requirements. The first step is to determine whether a condition triggers a special consideration. If it does, the physician must perform the SLU determination consistent with the requirements in the applicable special considerations section. If the condition is not listed or not addressed as a special consideration, then the SLU evaluation should proceed according to the guidelines' general criteria for that body part. Range of motion values for affected joints must be measured and documented according to the guideline instructions. As stated earlier, the chapters and the sections of the guidelines that are being utilized should be identified. 3 repeat measurements of active range of motion should be performed using the goniometer. All 3 measurements should be reported, and the highest should be used in the SLU determination. The physician may use a measurement other than the highest value, but must explain in detail why the highest range of motion was not appropriate. For contralateral measurements, range of motion for the unaffected contralateral joint, if appropriate, should be documented and utilized as a baseline for the SLU determination. There are times when the contralateral side may not be appropriate as a baseline, for example, if there's been a prior injury resulting in a functional impairment or an amputation. If the contralateral side is not appropriate, an explanation should be provided. If the contralateral side is not available for comparison, then the normal values in the 2018 guidelines tables should be used as a contralateral baseline. In general, ROM deficits that correspond with a 25% loss of use will fall into a mild category, 50% loss of use a moderate category, and a 75% loss of use into a marked category. We have a couple of case studies that will walk you through examples of how to utilize the guidelines to determine schedule loss of use. A 53-year-old man has a work-related injury to the right shoulder, and he's status post a right rotator cuff repair. His injury was caused by lifting a 40-pound box to shoulder height. He felt a sudden pop with pain and weakness in his right arm. Surgery was a year ago. He's at maximum medical improvement and working. Prior to surgery, he had full range of motion in both shoulders. Physical examination of the right shoulder reveals the incision site is well healed. There's no atrophy. Range of motion, forward flexion is 0 to 90, and abduction is 0 to 100. There are mild defects in external and internal rotation. The left shoulder has full range of motion. Utilizing the table from the 2018 guidelines, full range of motion for the left shoulder would be 180 degrees. Therefore, the contralateral shoulder has full range of motion, which is 180 degrees. In this case, abduction of 100 degrees and flexion of 90 degrees fall into the moderate category. Table 5.4a in the guidelines provides notes that contain additional instructions. If there are deficits in both flexion and abduction, the greater deficit must be used, not both. In this case, the greater deficit is flexion. A flexion deficit of 90 degrees falls into a moderate category, a 40% loss of use. Next, if the deficits in both flexion and abduction are moderate or higher and within 10 degrees of each other, an additional 10% can be added to the value of the SLU. Mild deficits of an internal and external rotations are not added to avoid cumulative values. To sum up this case, the flexion deficit is a greater deficit. It falls into the moderate category and gives us a 40% SLU. The flexion and abduction deficits are in the moderate category and within 10 degrees of each other, so an additional 10% may be added. The internal and external rotation deficits are mild, so they are not added. Please note, there is no longer a special consideration for rotator cuff tears. So to get the total SLU, add 40% plus the additional 10% for a total of 50%. Now let's take a look at case study number 2. This is a 59-year-old woman with a knee injury whose status post-right total knee replacement. Her surgery took place over a year ago, and it's been determined that she is at maximum medical improvement. The findings of the physical exam are as follows. The incision on the right knee is well healed. The range of motion for flexion is 125 degrees. There's full extension to 0 degrees. There's no instability or atrophy. The overall SLU percentage can be determined using Table 7.5, full or partial knee replacement, schedule loss of use. This can be found in Chapter 7 of the 2018 guidelines. You'll see that the patient's range of motion is greater than 105 degrees and extension is less than 10 degrees. These values fall into grade A, or good. There's no rotation or atrophy, so this patient is fully in the good category. This would make the SLU for the patient 35%. We will now review the revisions to the C4.3 form. Form C4.3a, Attachment A, is used to document an SLU determination. Form C4.3b, Attachment B, is used to document non-scheduled permanent partial disability assessments. Form C4.3 will continue to be used as a baseline for the submission of the impairment report. The attachments should be added to Form C4.3. Attachment A reflects the criteria for documenting SLU determinations according to the 2018 guidelines. Attachment B will not be reviewed at this time, but as stated earlier, it is for non-scheduled loss of use and reflects the criteria in the 2012 guidelines for the non-scheduled PPD evaluation. The provider should be sure to address all the body parts or conditions associated with the date of injury listed in Section A, Item 6 of the C4.3. This includes scheduled and non-scheduled losses that might occur as a result of or related to that date of injury. Providers should complete both C4.3a, Attachment A, and C4.3b, Attachment B, when both scheduled and non-scheduled impairments are associated with the date of injury. Section D of the C4.3 is used to address MMI and is unchanged from the current form. Attachment A is to be used to complete any SLU evaluation except for loss of hearing or vision and serious facial disfigurement. Let's review each exception. Hearing loss can be documented using Form C-72.1 for occupational loss of hearing, but for traumatic loss of hearing, Form C-4.3 with an attached narrative should be used. Vision loss should be addressed on the attending ophthalmologist report, Form C-5. As an alternative, Form C-4.3 with an attached narrative can also be used. Similarly, a report for serious facial disfigurement would be documented on Form C-4.3 with an attached narrative. Regarding Form C-4.3A, Attachment A, this form is used to document SLU assessments. Attachment A must be completed for all injuries or conditions amenable to an SLU. The provider must include all body parts and conditions treated that are associated with date of injury listed in Section A, Item 6 of Form C-4.3. The C-4.3A attachment was developed to capture the 2018 guidelines documentation requirements. For example, the form has sections to document the required range of motion measurements. As covered earlier, the provider must document 3 range of motion measurements for each applicable joint and use the highest value to calculate the percentage loss of use. If the provider does not use the highest value, space is available on the form so the provider can explain why that value was not used. Similarly, the provider must also provide measurements of the contralateral body part to use as comparison. In the absence of the required information, the workers' compensation law judge or the board can preclude the treating physician's report for lack of the required documentation. The provider has 2 documentation options for completing the C-4.3A. The first option is to complete the grid on Attachment A. The grid items are consistent with the 2018 guidelines requirements. Following the grid ensures that providers supply the required information. In lieu of completing the grid, providers can attach a narrative as long as the narrative contains all the required information for all of the body parts associated with the date of injury listed on Form C-4.3 Section A, Item 6. Now we'll address changes to the IME forms. The IME-4 cover sheet for the report of independent medical examination now requires that the start and end time of the patient exam and the total time spent reviewing records be recorded on the form. This information is being captured to fulfill the information requirements of an IME study that has been mandated by the New York State Legislature. Form IME-4 has attachments that parallel attachments A and B to Form C-4.3. Form IME 4.3A contains Attachment A for SLU determinations performed by IMEs, or independent medical examiners. Form IME 4.3B, Attachment B, is used for independent medical examinations for non-schedule impairment evaluations. It will not be discussed at this time as the 2018 guidelines address changes to SLU evaluations documented on the IME 4.3A. None of the policies, procedures, or processes associated with the independent medical examination has changed. Who you copy or what information you include is unchanged. The only difference is the use of attachments to document the examination. If you are performing an independent medical examination for an SLU, complete Form IME 4.3A. If you are performing an independent medical examination for non-schedule loss of use, complete Form IME 4.3B. Or you can provide a narrative that includes all the required information. Independent medical examiners should complete both Form IME 4.3A and Form IME 4.3B when both schedule and non-schedule impairments are associated with the date of injury. Again, the documentation required on Form IME 4.3A for the SLU mirrors what is required on Form C-4.3A. This ensures that both the treating physician and IME reports contain documentation that meet SLU requirements consistent with the 2018 guidelines. The bulleted items listed on Attachment A are included as a reminder of what must be included in the medical narrative, should you decide to use one, and to ensure that each grid is fully completed should you decide to fill out the form. Subject number 046-1011 that announced the revised forms indicated that the new forms would be available and had to be used as of May 16th. A clarification was made to the subject number, which was sent via WCB notifications. At this time, either the old or new forms may be used for performing an SLU determination, as long as all of the required information is included. If the independent medical examiner is using the old form, IME4, the information regarding the timing of the exam and the length of time for record review must be included in the report as well. It is anticipated that the electronic versions of the forms will be available in the near future. At that time, use of the new forms will become mandatory, but you will be notified when that happens. The 2018 guidelines are available on the board's website, as is the recent subject number announcing the forms. Thank you for participating in this training on the 2018 impairment guidelines. We encourage you to read the guidelines and become familiar with the forms and associated processes so that you can perform the SLU evaluations accurately and easily. Your medical opinion is important in workers' compensation claims and can greatly affect the benefits that a claimant receives. Thank you for the work that you do on behalf of injured workers and your contributions to New York's workers' compensation system. For more information, please visit the board's website at wcb.ny.gov/2018-impairment-guidelines.pdf or call customer service at 877-632-4996 Monday through Friday from 8:30 a.m. to 4:30 p.m. Eastern Standard Time.